the same is true with regard to these larger SNAP and Medicaid cuts, right? It's like, people will die resulting from loss of health insurance. People are already going hungry, right? Even with SNAP. So, like, all of those experiences are going to not only multiply, but are going to get worse for a lot of people who are already bearing the brunt of hunger and lack of access to healthcare.
Staten Islander News is speaking today with Paula Arboleda, Director of Public Benefits and LGBTQ Advocacy at Legal Services NYC in the Bronx. She co-manages a team focused on providing legal services to vulnerable low-income Bronx residents who need assistance obtaining, retaining, or increasing vital public assistance benefits such as cash welfare, rental subsidies, WIC, and SNAP, as well as public health insurance and home care services. She works with the LGBTQ Advocacy Project to provide comprehensive legal services to low-income LGBTQ people on a multitude of legal issues such as immigration, public benefits, and name changes. Prior to joining Legal Services NYC, Paula worked exclusively on healthcare and elder law issues as a senior advocate with the New York Legal Assistance Group. While at NILAG, she gained expertise working with Medicaid health insurance, Medicaid-funded home care services, the Medicare Part D prescription drug program, and related health insurance programs for low-income seniors. So good morning, Paula. It's good to have you with us.
It's great to be here. Thanks for having me.
Sure. So can you, I want to start out with, if you can please describe what Medicaid is, what it does, who it covers, and why it's important.
So, to put it simply, Medicaid is public health insurance. It provides free or low or very low cost insurance to low income children, adults, including older adults, and families. Basically, so they can go to a doctor, a specialist, get prescription medications, receive health screenings. And for people who are older or with disabilities, it can also provide long term care like home care and nursing home care. So it's, allows people to be insured and have access to healthcare, mostly for free or extremely low cost.
Oh, awesome. And where does the money to fund Medicaid come from? And is this similar to or different from Medicare? And if so, in what ways?
So Medicaid is funded jointly between the federal government and the state government. So, for example, in New York State, about 50% of the cost for Medicaid is paid by the federal government, and then the other 50% is split between New York State and the local county. Um, the difference between Medicaid and Medicare in terms of funding is that Medicare is funded entirely by the federal government, while Medicaid is split between the federal government and the state.
Okay. And which of those is the one that comes off of people's paychecks?
So with Medicare, you'll see a Medicare like sort of deduction, because Medicare is not based is not it's not a means tested program. What that means is that your eligibility is not based on how much income you have or how much money you have in the bank. It's basically based on age or disability. So a lot of the funding for the Medicare program does come from payroll taxes as well as other sources, right? In our paycheck, you don't see necessarily, a deduction that says Medicaid tax. A lot of the Medicaid funding, it comes from, revenues that the state collects that then is allocated towards the Medicaid program.
Okay. And is that generally part of like the FICA deduction? Like, so a person on their payroll check will see FICA, and one of the parts of FICA is to fund Medicaid, or
It's not really designated in that specific way like Medicare is. It's sort of like the state collects through payroll taxes and uses that money to fund different programs, which can include Medicaid, and it can include other public benefits as well as other public works programs and things of that nature. It's not like earmarked just for this insurance, right? Unlike Medicare, where like when you see that deduction, it is for the Medicare program.
Okay. All right. So the thing that people pay for in their payroll taxes is actually for Medicare and not for Medicaid.
Right.
Okay. When cuts are discussed, such as we're hearing about right now, that they're talking about cuts to Medicaid, where is the money that they're cutting from? Is this like additional funds that are being cut? Are they just cutting like for salaries or like where are the funds coming from that they're actually cutting?
So it's more, so it's not like, I mean, the cuts are being proposed in order to fund other things. So it's sort of about priority. It's not so much that, so like what they're saying is like if our priority is to reduce tax, if one of our federal priorities is to provide tax cuts to higher income people, that those tax cuts have a dollar value, right? And they're, quote unquote, there aren't endless amounts of money, right? So if you need to like spread the money that the federal government has, so the federal pie, right? If you're going to shift priorities and you want to spend more money in one area, sort of the concept that it has to be balanced against reducing costs in other areas. So these sort of proposed Medicaid and SNAP cuts is to take the money that the federal government would save through these cuts and use that money in other areas. And so the way that the cuts are being proposed are sort of in several areas, right? So you know how I mentioned that Medicaid is funded jointly, right, between the federal government and the state government. For New York State, for example, I mentioned it's 50-50. So one of the ways that the federal government can save money is at the expense of the states. It's saying, well, we're not going to pay 50% of our Medicaid share. We're only now going to give you 35% of the federal match for the Medicaid program. They could also decide to reduce reimbursement rates, right? So when you are a Medicaid provider or when you get Medicaid funding, there are certain rates that are set. You can't, think about like when you're hospitalized and they give you a Tylenol and they charge you like $500, right? Like with Medicare and Medicaid both, like rates for services are negotiated, right? Like you can't charge $500 for a Tylenol, right? There might be a Medicare, Medicaid rate for a particular service or things of that nature, right? So there could be cuts by just reducing reimbursement to hospitals, to doctors, to nursing homes, to Medicaid plans. So those are some of the ways that cuts can happen. They can also restrict eligibility. They can say, well, you can only get Medicaid if, right now, New York State has a very generous Medicaid program. A lot of the income limits are around 138% of the federal poverty limit, which is about $1,800 for adults and parents, and much higher for children, right? So it could be that now you change the income limit to something much lower, so less people can enroll. It could mean that for older adults who have a resource test for Medicaid, that the resource limit gets reduced, so less people are eligible and can apply. You could also reduce what Medicaid pays for. You could say, sorry, no dentist for you, no hearing aids for you, no Medicaid transportation, right? Or they can have enrollment caps. It could say, well, once we reach this number, no more people can join the Medicaid program. So these are all the different kinds of ways that Medicaid can be cut to lead to savings that savings in quotation marks, that would then make that money available for the other priorities that the federal government might have.
And so what you were saying about renegotiating the fees for services means that a doctor is going to provide the same service, but instead of getting a raise, that doctor's office is going to get a pay cut.
Correct. And the thing is, Medicaid rates are already kind of low. I don't know the exact per service, but compared to Medicare, for example, Medicare's rates are a bit higher than Medicaid. So what that's going to create is that you might indirectly incentivize providers not to participate in the Medicaid program.
Right.
And again,
Because it's not
having
profitable for them.
right. I mean, it's probably not profitable for them now, right?
Right.
But you rely on volume, right? Like that's kind of how sometimes that works for especially for doctors. But I think one of the things that you're going to often see, and that affects rural counties, right? Like maybe you only have that one hospital, or you only have those two clinics, right? So I think part of those cuts is also saying places might just shut down, right? And that could happen in New York City too. I know sometimes it feels like, oh, we feel it less because we're in an urban setting, but like a large number of hospitals get Medicaid dollars to keep hospitals open. If that gets reduced, hospitals may close, or there's going to be significant loss in staffing. People are going to get fired or laid off because they don't have enough funds, right? So that would directly impact like people in urban settings that have more choice, right? So the impact, would be widespread, regardless of the part of the state that you're in or the country, right? Obviously, for rural counties, it's like a much greater impact because you might not have a lot of choice, or the next Medicaid provider might be very far from you, right? That's not an issue we might have here in New York City, but again, it is an issue that would have like broad impact for everyone across the country.
And also, you were mentioning resource limits. Not everybody is familiar what that means. That basically means that a person who wants to enroll in Medicaid cannot have a house or a car or a certain amount of resources available to them that they could liquidate so that they could pay for their own medical care and not get Medicaid. Is that about something like that?
So generally so the way that the Medicaid program works in New York State is that if you're under 65 years of age, um, and aren't certified disabled, you don't have a resource test. For Medicaid eligibility, you have to meet an income limit and that's it. So if your income's over, then you might not be eligible for Medicaid and you might have to enroll in Marketplace plan or Essential plan, right? But your resources don't count. Um, when you're 65 and older, or you're certified disabled and have Medicare, you are subject to an income test for Medicaid and a resource test. And so the resource tests, I mean, the resources that Medicaid counts, they don't generally count the house that you live in, as long as the value is like, I think under $1 million or something, and it's exempt if a spouse lives there. But resources would be checking, savings, stocks, bonds, cash value of life insurance policies, things of that nature. It could also include certain retirement accounts, although those get special treatment. So that's when we say resources, that's what we mean. And also, it's sort of limited to these two major groups: people 65 and older, and people with disabilities who have Medicare insurance and also want or apply for Medicaid insurance. But for mostly everyone else, there is no resource limit. There is no resource test.
Okay. And have you seen evidence of waste, fraud, or abuse? And if so, in what areas is this an actual concern?
To be honest, not really. I think I'll offer is like from the client perspective. Most of the times, what I see is changes in clients' eligibility, like maybe their income went up because they started new work, or maybe they're going to retire soon, and so their income puts them over the Medicaid income limit. It's sort of like changes in circumstances, or a family member moves out of the household, so their Medicaid family size shrinks, right, gets smaller. So most of the issues that I see with like, and again, I wouldn't call it waste or fraud. It's people's eligibility changes, and sometimes there's a period that they stayed on Medicaid, when they weren't, eligible for the program. I don't really see that often. It does happen, and you can understand the limits. Even if the limits are great, they're not like super high, right? So it could happen to people. I think where I see some of the issues is around a lot of New York State's Medicaid program is through Medicaid plans. So most people, when they have Medicaid health insurance, they have to enroll in a Medicaid plan and they show their Medicaid plan card to go to the doctor or the specialist or the pharmacy and so, and so on. What I see is the other side, which is we pay a lot of money to these plans to administer the Medicaid program, and a lot of clients get denied for things that should be covered or that, in my opinion, should be found medically necessary. So a lot of my work in advocacy is on helping clients on Medicaid actually receive medically necessary care that is often denied for reasons that I think are financially motivated, right? A lot of my advocacy is around home care, right? Ensuring that people on Medicaid can age in place and avoid institutionalization, right? So a large part of my work is people who need additional home care hours, have tried 2, 3, 4, 5 times on their own, are constantly getting denied. And, I wish that my job was that I represented clients or my staff represented clients where like, maybe there was a dispute. Maybe we're saying, maybe this person doesn't need 12 hours a day. But a lot of the clients that I, represent and advocate for, it's not really controversial that they need a lot of these hours. And it's more that I think that there's a financial incentive not to approve these hours because it would mean spending more of the plan's dollars on care. So that's sort of where I see a lot of the issues with the Medicaid program, and not so much like these broad brushstrokes of like fraud and waste and abuse.
Okay. Um, and do you think that the perception of fraud and abuse is making it easier for the funding cuts to happen?
I feel like I don't know that it is. I feel like most of the attention on like fraud, waste, or abuse it tends to be focused more on welfare recipients, on people on cash welfare. I feel like there's some of that talk for SNAP, but I don't feel like generally there is a lot of talk about those issues for Medicaid. So I don't think that it's really that part that's motivating a lot of these cuts, right?
Okay.
I think there is a perception of like people on SNAP and Medicaid, like we need to make sure that, those who are getting it like are working. But like there's a lot of like studies that show that many people on SNAP and many people on Medicaid who can work are working. And so I think it's about like, it's tied into like poverty shaming, right? Like you don't get something for nothing, right? We need to, put all these like additional requirements in place, like work requirements, for Medicaid or SNAP or things of that nature, right? And it's like, but the statistics or like the studies show a whole other thing, that many people are already working, that in fact, a lot of people who are working are not offered health insurance, are not being paid a livable wage. So they rely on SNAP so that they can feed themselves and their families, right? And it's like a byproduct, like we're actually financing large corporations that then don't provide health insurance and enough income that allow people not to rely on these programs. But it's not the people themselves, right, that are not like, hustling or working or, or can't work, right, because they're disabled or older adults or things of that nature. So I think a lot of the narrative is just misplaced towards the people who benefit the most, but not the corporations that like don't provide livable wages and don't provide health insurance that people can afford
Right.
or adequately.
Right. And I know like with the Affordable Care Act was supposed to make all corporations have to offer health insurance, but I guess that in practice that kind of isn't really practical for certain salary levels, or there must be exceptions or something like that, right?
Yeah, yeah.
Okay. And one of the reasons why we were speaking to you also, which I had forgot to put in the list, was that there's a auto renewal that's been going on for the last 5 years that they're stopping now. If you want to talk a little bit about what that means for people.
Sure. So since when COVID started and back in March in 2020, I believe it was on or around March 13th, that there was sort of a pause on Medicaid renewals. Um, Obviously, for good reason, right? There was a public policy decision, and there was also waivers in place that allow, like New York State can't just decide to do that, right? Like the federal government gives permission to the states to sort of suspend certain like requirements, which include renewals. Um, and so part of that has been that for the last 5 years, people who had Medicaid as of that critical date in March of 2020 have retained their Medicaid whether or not they've renewed. And so, you know, those waivers and those extensions started, ending, and then states had to come up with a plan to get people back into like sort of the renewal clock and start, the Medicaid renewal process. And as you can imagine, the volume in New York State is pretty high. I think maybe last year, I think New York State covers a little less than 7 million people are Medicaid. Um, I think that's the number. So it's a lot of renewals. You can't do them all at once. Some of those renewals are handled by the New York State of Health, which again manages or administers Medicaid for people under 65 without Medicare. And then the local counties sort of process renewals for everybody else, which is mostly the older adults or people with disabilities and Medicare. So what's happening now is that you're not going to be renewed automatically. You do have to renew your coverage in order to continue getting all the services that Medicaid is paying for, right? So your transportation, your home care services, your nursing home care. If you don't have other insurance, then, to keep going for your cancer treatments or other treatments that you have, right? So what we're seeing is that many people just don't realize that this is a benefit you have to renew. And so people are not returning the renewals. So in New York City, for example, many clients, the first group of people who had to renew, and if they didn't, they could lose coverage, was the group that had to renew by May 10th. Right. So about 38,000 renewals went out to clients in New York City. Again, these are all the renewals handled by HRA or, the local county. And I think as of last week, maybe 22,000 have returned them. But that still leaves about 16,000 people who did not return a renewal. We're going to get a letter that says, we're going to discontinue or take your Medicaid away. And this is just for the group whose renewals were due May 10th. There's going to be a new batch of tens of thousands whose renewals are due June 10th, right? And if they don't return them, they're going to get a letter saying their Medicaid will be discontinued. And again, this is a lot of our older adult clients, a lot of our clients with disabilities. So of course, we're very concerned because, if they don't return it, they will lose this insurance, they will lose Medicaid, and then all the services that Medicaid is paying for. So they might not realize it until the aid doesn't show up, or they get a call from the agency saying, your Medicaid's not working, we can't keep sending you the home care. Or their transportation doesn't, arrive because their Medicaid is off. So, again, we're very concerned, and people should definitely seek legal help from us and from other organizations that, are working with these clients to help them, appeal that discontinuance, help them renew, help them fix the issue. But we want the word to get out that if you get this renewal packet in the mail, it looks daunting. It's like 15 pages. You have to look at it. Please renew, please return it, because we know that the consequences can be very dire.
Right, right. And so, does it seem like that it's likely that cuts to Medicaid, SNAP, and Social Security will happen? And how will this affect constituents in New York, as well as how will it affect constituents in poorer states, such as the Appalachians, as opposed to New York and New Jersey, which are wealthier states that, like we were talking about before, they might be able to make up for the downsizing?
So in New York specifically, so New York State has a pretty robust Medicaid program and Medicaid's coverage of long-term care, so specifically home care and nursing home care. Um, so if if there are cuts, right? I mean, we talked about all the ways that the cuts could happen. It could jeopardize nursing home operations. It could jeopardize the availability of home care. It there could be changes to there could be a cap to how many home care hours that you receive, right? So all of those things would affect people in New York State. There are some states that don't cover home care very much. So maybe in those states that impact would be minimal, but it would have a huge, huge impact in New York State. Um, there you could just see reductions in eligibility, reductions in Medicaid enrollment for children and families, right? Just overall. And we talked a little bit about the rural communities, right? Where like healthcare is more limited and you could see clinic closures, reduced staffing. But again, we may see that as well, again, because a lot of our hospitals do rely on Medicaid funding. In terms of SNAP is mostly funded by the federal government with some administrative costs paid by New York State through the Office of Temporary Disability Assistance. So we talked a little bit about how these cuts could affect New York, but also, other places more broadly. If you expand work requirements, there could be loss of food assistance for, hundreds of thousands of people. SNAP is the most effective anti-hunger program for families and children. So you're looking at increased food insecurity for children. You're looking at, there's a lot of studies on the long-term effects of food insecurity, the effect of performance and behaviors in schools when you're hungry. There's also a direct economic impact, right? A lot of our SNAP dollars are spent locally at grocery stores, at bodegas, at farmers markets. If there's less SNAP benefits, right, either because we reduce the maximum that people qualify for or we reduce the number of people who are eligible for it, that's going to directly impact the local economic infrastructure, right? Because I think the rate is like for every dollar spent in SNAP, I think it contributes like $1.60 to $1.80 to the local economy. So you're going to see the impact of that on businesses. You're also going to see the pressure on food banks and charities, right? Like, I think there's been more enrollment in the SNAP program and continued Medicaid since the pandemic, and those are all good things. But if less people are getting SNAP and or getting less SNAP, because we know SNAP doesn't, like for a single person, you're getting $292. Like, okay. I mean,
that's actually
a supplement, right?
That's up from a few years ago. It was 180 before the pandemic for the
right,
whole month. So now it's
right. So,
292.
and
Okay, that's
you
better.
can't, yeah, it's better. But again, there's certain things you can't buy with it, like toilet paper, paper products, things like that, right? So people are already supplementing. It's not like your food bill's like, I'm all good, I'm all covered, right? For the amount of money that people get, but it's a large help to people, right? So there's going to be more pressure on food banks and charities to sort of, mitigate the impact, but they're not going to be able to fully absorb all the impact that that's going to have. One of the major proposals in the bill is shifting the administrative cost to states, right? So right now it's about 50%. They want to increase that to 75%, meaning that New York State would have to absorb 75% of the cost to administer the program, right? Like all of these things, like, right, like to process renewals, to manage appeals and errors, right? So like if you're shifting more of that cost in New York State and you're adding additional requirements, there's just going to be more New York State dollars spent on these administrative burdens that may force cutbacks somewhere else, right? So these are some of the impacts that it would have in New York State specifically. In places like, for example, Kansas or Kentucky, Kansas specifically for Medicaid, 2/3 of their Medicaid program is financed by the federal government. So that's 66%. That's obviously on the higher end. So again, that would, significantly increase its own spending. It could lead to much more reductions in services or eligibility of provider payments. The same for hospitals. And they anticipate that these Medicaid cuts in Kansas could lead up between a 5 and 50% loss of coverage of current Medicaid enrollees. Like they just couldn't cover as many people as they do now if they have to spend more of their state money for the program. And then of course, job loss in health and jobs lost in healthcare, in the healthcare industry. Because again, some of those would come from the federal funds, like decrease in federal funds and Medicaid and SNAPs, like would have an impact on healthcare jobs in that state.
Okay.
And very similar in Kentucky as well. One of the other things to mention for Kentucky specifically is they have quite a bit of school-based health clinics, many of which rely on Medicaid funding. So of course it would impact student like health services, which, we know are very important.
Okay. And how would funding cuts to, for example, the NIH, the World Trade Center health programs resource provider, the CDC, and other government organizations affect everyday Americans?
Yeah, so I think I guess some of it is discussed, but I feel like, people, like if I'm, I'm a working person trying to raise a family in a very expensive city, I'm probably not always thinking about NIH, right? But I think some of it is like, it does slow medical research progress, like, cancer research, Alzheimer's, diabetes, COVID-19. It also has an economic impact, right? Like loss of jobs in universities, hospitals, biotech companies. Like, so funding cuts to the NIH can have all of those impacts. And similarly to the World Trade Center health program, right? It would limit access to critical care and support for first responders and survivors of the 9/11 attacks. Long term, if you don't get critical care now, worsening conditions and health outcomes, right? Because if you're not getting the support to get the treatment for a healthcare need you have now, most of us, if we can't afford to pay for it, we just go without, right? And there are long-term effects of that by having more acute, maybe acquiring like more acute interventions, maybe hospitalization or just a worsening condition overall. For CDC, it affects our ability to detect and respond to epidemics or pandemics. As something as simple as the flu, now you're seeing measles, monkeypox, COVID-19, right? So, cuts in those areas directly affect what is our plan to deal with a new epidemic or pandemic, right? It's also, for example, funds towards programs targeting smoking cessation or maternal childhood health, opioid addiction, chronic diseases. Those programs may be scaled back, right? Which we know any of, maternal and child health are very important. We know the impact that smoking has on people long term. So all of these programs, could lead, sort of cutbacks in those programs could lead to worsening health disparities or increased preventable illnesses. And then the last part really is around preparedness for natural disasters, bioterrorism, other health emergencies, right? So cuts to the CDC could affect our preparedness in some of these areas, right? And that would, have devastating effects for, we're seeing lots of flooding, we're seeing tornadoes, all of those things affect the communities that are affected by it, but other communities, as we see, like climate change affecting more and more people or affecting more and more people.
Right. And I know, like we had published there was a Senate Committee on Aging that talked about some of the cutting edge research that the United States has done because of a lot of the NIH funding, where we're kind of number one or number two in aging research. And the gentleman who was testifying said that if these cuts do go through, our place in that is going to be compromised. We're not going to be number one for aging research anymore. And also aging research, for anybody who doesn't know, the most effective anti-aging treatment is diet, nutrition, and exercise. It's better
Mhm.
than any pill they found and any medication, any pharmaceutical. So encouraging people to, eat more healthy, eat more plant-based foods and more protein and exercise more would get rid of like 40% of the chronic conditions that a lot of people have. So when you looking at like Medicare and Medicaid, who are the groups most likely to be most strongly affected? So is it like elderly people, children who have lost their parents, low income people, certain races that are affected disproportionately? Like who is going to be feeling the impact of these cuts the most?
So your deaf children, absolutely, as you know, when I discuss the cuts in SNAP, right? There's high participation rate among families with children. Obviously, the older adults or elderly, many of them on Medicaid are dependent for long-term care, as well as food assistance. Um, People with disabilities, right, rely especially on Medicaid health insurance for health care and supportive services. And we've talked about, low income people generally, right? Um, depend heavily on Medicaid and SNAP for some other reasons. Many are already working or, they're referred to as the working poor, right? And sort of use a lot of these programs because, they don't earn enough to be able not to rely on these programs. And we've already talked about the significant impact it would have on rural populations with food deserts, limited healthcare access. It would, further entrench those issues that they face. I think that, I think it's going to affect, a lot of communities in the United States, but of course, the impact is not going to be felt equally, right? We already have, deep inequality, right? We already have, health disparities, right, amongst race, gender, and or ethnicity. So all of those are going to deepen. All of those inequalities and health disparities are going to deepen through if we're limiting access to these programs, right? And to research, right, around aging and other chronic conditions that are pretty common in the United States, like diabetes.
Right. So I wanted to just ask, so you were mentioning which of the groups are the likely to be the most strongly affected, and are the people likely to be affected considered marginalized groups? And how can we ensure that their voices and stories are heard, especially before the cuts are put in place?
Sure, absolutely. So I think many of the, groups that would be affected, are going to be people of color, older adults, LGBTQ people, immigrants. For example, I think just yesterday there was an article on research that was funding, um, like research funding focused on queer rural communities, right? Those communities just there hasn't been a lot of like study and research on their experiences, right? And because of changes to research and funding, like that research just stopped. And all the people who were participating, all the people who were supporting the efforts, like now, right? And it just seems so small, but it's like it's important to study, you know, groups of people who are marginalized to better understand both their needs and their strengths, right? And I think that's just like a microcosm of like, if people aren't wondering about your experience, you really do become invisible. And it's easy to sort of further other that group or community we're not like aware of or thinking about. And when things affect them, we can turn an eye, right? Because we're not thinking about them. We're not involving them in sort of our day to day. And I think a lot of the research is also about like, what is impacting people that are often left out in our society, or that are, often discriminated against or marginalized. And I think, the same is true with regard to these larger SNAP and Medicaid cuts, right? It's like, people will die resulting from loss of health insurance. People are already going hungry, right? Even with SNAP. So, like, all of those experiences are going to not only multiply, but are going to get worse for a lot of people who are already bearing the brunt of hunger and lack of access to healthcare, and chronic conditions that we know adversely affect certain communities more than others, right? So I think those are the kinds of things that, those are the clients that we work with day to day, right? And who are going to be immensely impacted.
Okay. And immigrant workers, including those here legally and illegally, have long been required to pay into the Medicaid and Medicare system, despite being unable to then apply for or receive those benefits. Is it the case that these non-citizens have been able to receive benefits from Medicaid, as multiple politicians have claimed, or are there any non-citizens or naturalized citizens that can receive these benefits legally?
So that's a great question. So, like, the interaction between Medicaid eligibility and immigration status is often misunderstood and very much politicized. Politicians sometimes conflate emergency Medicaid or limited state funding programs with full Medicaid benefits. So it can sometimes lead to false claims that undocumented immigrants or, non-citizens without an immigration status are broadly receiving Medicaid, when that's just generally not true. I can explain. Non-citizens without immigration status can only generally qualify, like I said, for emergency Medicaid to treat an emergency condition. Okay, like fell on the street, broke my arm, don't have status, go to a hospital, they can apply for emergency Medicaid for the treatment of that condition, right? It's not health insurance like regular Medicaid or full Medicaid, where you can then go to specialists and doctors and get medications. Not that that would be a bad thing, but that's not what we cover right now, right? Pregnant people without status can receive Medicaid for pregnancy-related services. Children without status can enroll in the Children Health Insurance Program, which is not the same as Medicaid. So really, those are the avenues for healthcare for people without an immigration status who are quote unquote undocumented. Part of the other side of that coin is that there are many non-citizens who are eligible for Medicaid and should enroll. Legal permanent residents, refugees, asylees, anyone who's filing an application with the U.S. Citizen Immigration Services. So, for example, I want to apply for asylum, or I filed a VAWA self-petition because I was abused by a U.S. citizen, a legal permanent resident. Anyone with a pending application, an immigrant with a pending application before the U.S. Citizen and Immigration Services, can apply for Medicaid. That is allowed, right? So I think there's two conflations, right? I think we call many people who are trying to get a status and are in the application process and have filed something. I think we lump them in with people who have no status at all. They have no way to file any application. And that group can actually apply for Medicaid as long as they meet the income limits, right? And the other requirements. And truly, the people who are truly undocumented, they can only really get emergency Medicaid, and their children can get CHIP. And if they're pregnant, they can get pregnancy-related services, but they don't have access to full Medicaid coverage like I described at the beginning.
Okay. And they obviously, if they're undocumented and migrant workers, they're probably just being paid cash, so they're not actually paying, like having like a paycheck and stuff like that. Right? Is that correct? Or do they also have a paycheck and they have to pay, the FICA and all of that stuff?
So it just largely depends, right? Because if you don't have any pending application, then and you don't have a work authorization or social security number, some non-citizens do apply for an individual tax identification number that does allow them to file taxes, which then can include payment of certain portion of these kinds of taxes that we would see taken out of our paychecks. If they're one of the non-citizens who has a pending application with USCIS, because those applications take forever to be processed, they might get a work authorization and a social security number that does allow them to work. And if they are paying, if they're working any job that's on the books, just like anyone else, they would be paying that FICA taxes and Medicare taxes.
Okay, cool. So, is there anything else that you would like to add today?
I would say like the bill hasn't passed. We still need to, make sure, especially if you're living in areas where I think we need to, call our representatives and both support them if they've been opposing these cuts, as well as encouraging them not to support them if they've been on the fence or have been proponents of these cuts. Like the impact really is going to be devastating nationwide. Of course, the cuts are not going to be effect tomorrow, even if the bill passed the Senate, but the long-term effects are going to be felt, I think, by everyone in the United States. And many industries, both ones that we could have anticipated and others that we, don't.
Right, right. Okay, well, it was really, really great to speak with you today. And I appreciate you taking the time to talk with us.
Thank you so much. Let me know if you have other questions or anything comes up. And
Thank
thanks,
you.
Anna, for coordinating.